Hi, everyone. I want to thank you for joining me and my special guest today, Dr. Stuart McGill, on the podcast from jessephysio.com. For those that don't know, but I'm sure most of you do, Dr. Stuart McGill is a professor of spine biomechanics at the University of Waterloo. He is the author of 3 textbooks and over 300 scientific publications that address issues of low back function, injury mechanisms, development of evidence-based rehab, and performance enhancement. As a consultant, Dr. Stuart McGill has provided low back expertise to government agencies, corporations, elite athletes, teams, and Olympic programs from many countries, and also legal firms. He's one of the few scientists who regularly asks for consult by the medical and sporting community regarding particularly difficult lower back cases. I want to join into the program Dr. Stuart McGill.
Yeah, well, good morning, Jesse.
Thank you very much for coming.
The audience may be interested how this came about. We met in person just a few months ago for the first time and had lunch together, which I enjoyed very much. So
we sure did. I bugged you.
Yeah.
Yeah, I was presenting on the first day of the Ontario Medical Association conference, and I think you were there on the second day. And I listened to your wonderful talk, and afterwards I hunted you down at lunch, and I talked to you for a while, and you were very gracious in answering all my questions then, just as you are now.
Well, we'll see about that. But anyway, I heard only good things about your talk as well. So there you go.
All right. So we're just going to ask questions that a lot of people that I speak to, both on my social media websites and also in person, have a lot of inquiries about some of your work. So I've kind of compiled a list of stuff that I think most people would like to know. So here we go. We're going to get started, okay?
Okay.
Okay. So one question a lot of people ask when they go to the gym, are there certain exercises that you would encourage those with lower back pain to avoid? And if so, why?
Okay. Well, I get, literally hundreds of emails a day, and quite a few of them will be asking that question, can you give me some back exercises for my back pain? Or what should I be doing in the gym or throughout the day? And my answer is always, and you're going to know this, it depends. What exercise will hurt one person helps another. And I can just give an example of, say, a kettlebell swing. We've investigated the mechanics of swinging, as you know, and it will really help certain kinds of backs. But what we measured was the kettlebell swing is a little bit different from a lift in that as the kettle comes through the swing up to top center, a shear load is created on the back. Now, that would not be any issue at all for many people. But it would be if someone had a shear load intolerance. So you test someone, maybe something. Well, we found the prone instability test to be a good predictor of who should probably not swing a kettle. You could do the same thing with, say, elliptical trainers. Some say, the elliptical really helps my back, and others say, no, it really tweaks my back. And when we measured the mechanics of that, for example, we found those with very mobile hips generally don't complain about it. They like it because there's no load that gets transferred to the spine. The elliptical trainer is very gluteal muscle centric as opposed to walking, say. So it has a role. And yet, if the person has stiff hips, the lack of mobility goes right into their back and loads it up. And so, when you investigate these things, you start to realize that an exercise might have a benefit for someone if you're attending to their particular goal.
Right.
And it'll hurt the next one. So that's the short answer to the story. But if you will permit me to give a more broader background, I think we can then really get to the meat of this. Can I take 2 or 3 minutes and do that?
Absolutely. My pleasure.
Okay.
Go ahead.
Your question was exercises for those with back pain.
Yes, because in the clinic, a lot of clinicians are just ask blanket statements. What do I do for my back pain?
And I get that.
Okay.
Well, there lies a huge issue. There's no such thing as non-specific back pain. There's always a cause, And a proper assessment will reveal the cause, and it will allow the clinician to subcategorize the patient into categories based on what triggers them. Now they're guided and given direction of what they should do and shouldn't do, not only in the gym, but all day long. So my assessment, people should probably understand this. It usually takes me 3 hours to do a full assessment on a back. It starts with the second I lay eyes on them, just noting how they're moving, where their stiffnesses are, where their mobilities are, their movement habits, how they choose to take their shoes off. Do they express themselves by using their hands, which might be loading up their back if they've got a terribly chronic back, for example. And then I just listen to them. Small talk is very important. I deduce what their priorities are in their life. Do they just want to be able to play with their kids without being affected by their back pain? Are they worried about providing for them and working? I'm trying to understand their learning style. Will I need to be touching them to give them movement cues, or will I simply be able to speak to them? Do I need to encourage them? Do they like movement? If they dislike movement, I'm going to have to work on simply encouraging them to move. But if they say, I have to go to the gym every day and do 30 minutes on the treadmill and elliptical, otherwise I'll go crazy, I'm getting a clue now that I have to dial back their exercise and load exposure. And then I now have some clues as to what I'm going to test physically. So I'll do specific pain provocation tests. I test motions, postures, loads, and I try and create the pain. So I understand very precisely what combinations of those increase their pain. Then immediately, as soon as I've created their pain, I try and reduce it. I do it through posture changing. I might add a bit of stiffness. I might take a bit of stiffness away. I might get them to relax more. I might teach them how to move, avoiding the pain trigger, which could be, it could be a compression. It could be a shear. It could be a bending. Who knows? But now we're starting to arrive to quite a precise diagnosis in terms of the pain trigger. So, let's take say spine flexion, which is probably one of the most common triggers of the patients who are sent to me. I show them right away, well, if you don't do that, you can tolerate load. And this is quite liberating to them. No one has shown them, again, in the past, what their pain trigger is, and they've feared brushing their teeth or tying their shoe or even sneezing. They say, I sneezed and threw my back out. No one took the time to explain what their particular triggers were, and they did become fearful. So it's very empowering for them to be shown and for them to understand where their risks lie and how to avoid them. So, we can talk about the role of pain science and all that kind of thing, which, I think we've incorporated for at least 20 years. But let me get on now with really trying to answer your question. And I know you know this. We've rehabilitated a lot of sort of celebrity athletic careers, I guess. Mm-hmm. And sometimes it's been in tuning a very appropriate mobility and stability continuum. Sometimes we have to add more endurance so that they can train with strength and keep better form for a larger volume of training. Every athlete, every great one who we get, they're managing something. None of them have a pristine back. And anyway, maybe that's enough for now. But
sorry to interrupt, but I guess one of the, as a clinician, one of the common themes or I guess practices that, for good or bad, that a lot of clinicians tend to do is they read one of your articles on your big 3 exercises, like the bird dog, the side plank, and the curl up, and then anyone with back pain is given those as kind of just do these and you'll be fine, kind of basically bastardizing some of your work and just giving people those three things and crossing their fingers. What are your thoughts on how just giving those three exercises to those with back pain, and I know back pain is a very dichotomous term, how do you think they would respond to that?
Well, it saddens me because the first order of business is to stop the cause. I'm going to tell a little story now. I think this is in every one of my textbooks. Let's hit your thumb with a hammer over and over again, very lightly for a few days. In the beginning, it doesn't hurt, but after day 3, your pain in your thumb is so highly sensitized that everything now hurts. Lightly touch your thumb and you'll scream. If you did the big 3 exercises on your thumb, it would only cause more pain. The first order of business for the clinician is to show the patient what is causing their pain and get rid of that. Now you're creating, and in so doing, you're winding down the pain sensitivity. Don't start exercise adding more load to someone's back who's already hurting. Stop the cause. Now you have to decide whether more stability in their back is going to help them. So the big 3 may be very appropriate as stage 2. We evaluated many different exercises, trying to find the very best ones in terms of what spared the back, but also guaranteed stability. At the time we were having debates with the transverse abdominis centric people and whatnot, and we were measuring stability. So we couldn't go along with that. We had to go with what science showed us were the best optimization of stability. And then, we developed some assessment tools, and then we took tools from others. The prone instability test I got from Dave McGee's textbook. Right. On orthopedic assessment, which is a fantastic book, by the way. But we tested that exercise. We trialed it in the University of Pittsburgh hospital system, 5 independent hospitals. The first author on that was Greg Hicks. And that one exercise, McGee's prone instability test, predicted who would do well with spine stability exercises, namely the big 3. So you're starting to see there's so much more to the story. And I think clinicians, I know many do, I know you do, but there is a large group of them that just want to follow the cookbook approach. Oh, everybody gets McKenzie exercises, or everybody with back pain. Everyone with back pain should get stability. It's not that way at all. Do a thorough assessment and let it guide you.
I agree. And I think one of the other benefits of the approach you're using is I find that if you're giving a patient an exercise, whatever the case may be, whatever body part that might be, if they don't know why they're doing it and if it helps immediately, the likelihood of adherence drops right down. So if you're showing them their pain triggers, if you compress their spine into flexion and that creates their pain, and then you show them exercises that reduce that, they're like, okay, there's a very simple cause and effect that will dramatically help those who are shaky as to why they're doing what they're doing. And I think more clinicians need to be on point with making sure they prove to the patient not just that they should be doing it, but why.
Oh, it's just so empowering to the patient. Thank you. Anyway, that was a nice summary. Hey, do you want to answer these questions for me?
No, I think people want to hear you. All right. My next question is kind of a personal one, but one that I've talked over, a few beers with a few other colleagues, and I want to get your take on it. So we find that your tasks, especially your latest one, back mechanic, are heavily focused on avoiding pain triggers to pain and exercises aimed at spinal stiffening without much mention of passive care. Do you feel that manual therapies such as spinal manipulation, mobilization, or other soft tissue techniques have a role in helping those with acute or chronic lower back pain?
If you were to ask me that question 30 years ago, I probably would have said it has much less role. depending on the day that you caught me. But I think I have enough science now and enough clinical experience to answer that a little bit differently. And you guess what the answer is?
It depends.
Exactly. Thank you. So I can tell some stories there. I had a great Olympian, a medalist, and I won't tell you too much more because it will reveal the person who it is. But nonetheless, they had been doing a heavy squat protocol and step ups with a bar on their back. And they were going more for volume and they were sacrificing form. They ended up getting quite a nasty disc bulge that disabled them. They could no longer train and they were 2 years out from the next Olympics. So I did what I could in stabilizing. I showed them some vacuuming therapies for their disc bulge. The disc bulge was reduced. All was well. But there was one last piece of the puzzle that I couldn't figure out. There was something going on in one of their quadratus lumborum muscles, and I just don't have the manual skill to release that. I sent them off to one of my colleagues, and I have colleagues all around the world who are soft tissue gurus. And this person did appropriate manual therapy on them, a little ART and whatnot. And within 2 or 3 treatments, they solved the problem. They released the muscle that I could not. So to answer your question, I work with certain manual clinicians. Some of them are awful. They just mobilize everything. They're non-specific. They think general massage will help. But they're the real good ones who really target their therapy. They know what to release and what to leave alone. Don't stir up the hornet's nest. And they make me look good. So there's a time and a place. Absolutely. Should everyone get manipulation? Absolutely. No way. But when it's the right person with the right presentation, it's all part of the puzzle. So how is that?
Yeah, so it sounds to me like you're a fan of the clinical prediction rules for those who would be benefit from more of a stability approach versus spinal manipulation as a treatment technique. Is that fair to say?
It is, but only to start. So
Okay.
the clinical prediction rules to me are a fantastic start, but then they're too gross. So the patients I get, and I know you realize this, but the listenership should probably realize that the patients I get are rather special. In order to see me, they should probably have already seen maybe 10 or a dozen different clinicians already, and they failed or they were made worse. So they're the difficult cases. And maybe that's why I have to consider every single one of them as a subcategory N equals 1.
Got it.
You know what I mean? So I'll start with gross subcategories, which may work in the average clinical practice, but for me, everyone, they're so unique that they actually form their own subcategory, and I have to figure it out.
Okay, fair enough. So another question I have is one based on just the assumption of your work. You've been called the anti-flexion guy by some. Flexion in terms of sit-ups, bending forward. Some have stipulated that you believe that bending forward repeatedly, regardless of the person doing it, is a bad idea. How would you respond to that characterization?
How do I respond? Well, I would say some people have been very irresponsible in not understanding my work and then commenting on it. You know, I know there's sound bites all the time, and that's just the world in which we live. They may not realize that I'm talking about back pain or a specific person in pain, and then they generalize that. Let me just tell this little perspective story. When I started out, it was just over 35 years ago now, I would meet well, first of all, I'd read about some of the great spine people in the world at the time, people like Harry Farfan, Jeff Maitland, Lance Toomey, Bill Kirkcaldy-Willis. And I would read their works, really study them. I thought I knew what their perspectives were, and then I would meet them. at different conferences and go to lunch with them and whatnot. And then I realized that they were so much more deeper thinkers than I had ever imagined. To every single one of them, they were very humble and willing to discuss. And then after that, I met, Vladimir Yonda, Gordon Waddle, Shirley Sarman, Paul Hodges, and more recently, people like Gray Cook. And as you know, I've had to publicly debate quite a number of these people. And every single one of them was a fantastic personality. We never hated one another. We enjoyed one another's companies. We always have a beer together at conferences, and yet there are disciples of me and disciples of some of these other people, and they're willing to commit murder for whoever their anointed guru is, which is it's not the way it works with us at all. So I just wanted to mention that this interview today is really a nice opportunity to get past the soundbite stage. So I hope that gives a little bit of a perspective on how people see, say, scientists who've done a particular volume of work. Thinking of Harry Farfan, this just came to mind, but some of your young listeners might appreciate this. Do you want a quick Harry Farfan story?
Sure.
Okay. I was a PhD student. This would have been 1983. We hosted the international biomechanics meetings, and Harry Farfan was the keynote speaker, and he wrote the book Mechanical Low Back Pain, which probably everyone should read it. Anyway, we went to lunch, and Harry spoke like James Earl Jones. He had that voice like you were talking to God, just amazing voice. And he said to me, he says, so what's next for you? That was some nice work that you presented today, and this is going to surprise some people. And I said to him, Dr. Farfan, I don't know if I can continue my PhD or not. I am so deathly afraid of public speaking. I get physically sick going in front of the microphone and speaking to people. And he looked at me and said in that James Earl Jones voice, he says, he said, look, let's solve this problem. If people ask you to speak, they're interested in what you want to hear. If they're not interested, they'll never ask you again, and your problem is solved. So just keep doing your work and don't care so much. Just go and tell them the way it is. And I have to say that probably at that particular time was the biggest thing I could have heard and kept me going. So anyway, there's my little Harry Farfan story.
Okay.
But anyway, back to answering the question now, am I the anti-flexion guy? I'm going to answer this at two different levels. Let's take an individual patient who is now sitting in front of you. You test them and you determine that flexion movement is their pain trigger. So you have to show them that and show them strategies to avoid that, to allow them to desensitize their pain trigger. There's no way around that. But then we get to populations, and injuries form clusters. For example, if you take a rowing program, depending on the coach and the strength and conditioning coach, there will be a very high incidence of, say, disc herniations among that particular population with a particular rowing stylistic coach and trainer. So I'm not going to say you can't flex, because that's rowing. But what I would advise is control the cumulative flexion exposure. I can think of other examples. There was a guy on the internet who said, I followed McGill. I stopped doing flexion. I became weak. And I thought to myself, what is he talking about? Is he talking about flexion movement or flexion moment? He didn't know. So, all I can say is he deserved his weakness. If you take some of the MMA fighters that we've worked with over the years, and some very high profile ones, it's tradition in mixed martial arts to do 1,000 sit-ups every day, because they have to build that abdominal armor to withstand the leg kicks and hand strikes that they do. That's
exactly. And for them, that's, I guess you call a functional exercise.
it absolutely is. But here's the rub on that. When they're 22 or 23 years of age, their discs are starting to become sensitized. They can no longer train jujitsu and do the 1,000 sit-ups anymore. In fact, they can't even train at all for the octagon. So I'll see them and I'll say, well, look, what are you doing? Oh, well, I do 1,000. I lay on my back on a gym ball and I curl over the gym ball 1,000 times. And I say, well, look, that's your pain mechanism. You can't train now. So what we're going to do is maintain the flexion moment, but reduce the flexion movement, and we'll get the disc to settle down. And so then we'll say, let's turn over on the gym ball and we'll do stir the pot. Let's lock your back in a pain-free position. And now all of a sudden they're back training pain-free, and we've restored their UFC career. Other examples I can use in our work with the U.S. military, the Canadian military as well. They both had speed sit-ups in their annual fitness test. Myself and a group of experts consulted with the Canadian military a dozen years ago, and they realized, not only through our work and not only through pig spines or any of these other things I hear on the internet, they epidemiology, they looked
My next
at
question.
Yeah, well, okay, we'll go there. They looked at epidemiology, who is getting hurt, why, linking it to numbers of sit-up cycles and whatnot. And they decided to take it out of their program, and they replaced it with much more functional tests. The U.S. military is now changing as well. This takes an act of Congress. They're not going to listen to one scientist. They really pull in a lot of experts and create a broad consensus. And they have found it's wiser. You get healthier people, avoiding the speed sit-ups, which is repeated flexion. A very nice study that was done by Deidre Tayan and John Childs. They did it down at the Army base in Texas. What was it? Oh dear, I've forgotten. Anyway, they ran a controlled trial where they took some new recruits and they did the traditional boot camp sit-ups and all of that. And then they tested their sit-up score at the end of boot camp and their back pain profile. They took another group and they said, we're not going to train the test. We're not going to do repeated flexion sit-ups. In fact, you're going to do planks, push-ups, flexion moment exercises. Now, guess who got superior sit-up scores at the end with less back pain?
Group two.
Yes, thank you. So these people again want to simplify, and they don't know the breadth of perspectives that are considered in this. I'll just talk about the discs as well, and how you can't have it both ways. You can't repeatedly flex the spine and then expect to bear heavy load. So with repeated flexion, the collagen fibers that make up the annulus, they're held together with a gooey ground substance. That's the glue, so to speak. You soften the ground substance with repeated motion. If you keep softening it, you get more mobility. Fair enough. But if you then say, now let's do heavy deadlifts with poor form, that disc will now succumb sooner. It will herniate faster. However, if you look at the great powerlifters, the grand old men and the grand old women of powerlifting, they can hardly tie their shoes, and many of them can't. They've had to stiffen their back by not moving it in order to bear the high load without the collagen fibers delaminating. So you can't have it both ways. You must have purposeful training. So am I the anti-flexion guy? If a person wants to lift heavy loads, I would say control the amount of flexion exposure. If you just want to have a happy life, tie your shoes, and all of these kinds of things, when you're taking high load, of course, avoid cumulative flexion. That makes good sense. It's a good general health recommendation. But if I said never flex, this is just people who are misrepresenting our work.
And one of my personal arguments to those that say you shouldn't flex is simply the fact that we have a 3-joint complex in our spine, and it was made to bend. It was made to flex, extend, rotate. Obviously, there's evidence to show that repeated flexion with load can cause delamination. But at the end of the day, people are saying never flex your spine. And I've had patients walk into my clinic so upright with the fear of God bending forward. They were told that they should never flex their spine, that they're scared to bend forward to tie their shoes or pick up keys on the floor because they're so afraid of movement, which is just terrible because that sensitizes a whole other area of the body that doesn't necessarily need it.
Well, can I comment on that?
Sure.
Yeah. That's just bad coaching. And I see this, unfortunately, among certain clinicians. You can, there's a trend with some clinicians who say, don't worry, just keep moving. And I think that is so irresponsible because some of those people who keep moving, they stay chronic, they stay chronically or repeated acute episodic, and they don't realize that it is a certain motion that's allowing the acute attack. And for them to learn, a specific movement under load and under a cumulative condition, that's the precursor to my attack. And yet, there are others. So my point was there. It's so empowering for them to realize that. And they say, okay, well, for my particular back, I've got to be a little bit wary. But then when I see clinicians say, don't ever flex your spine, this is fear inducing as well. But any system will cause fear if it's got bad clinical coaching.
Okay.
And I think as clinicians, we have to be very sensitive to the quality of the coaching, showing them how to move. And if it's an issue for a particular individual, you address it. But if it isn't, don't worry about it. Go have fun. I've done a lot of studies on this. Jesse, we did a study measuring Middle Eastern belly dancers. Well, there's no one who has more controlled mobility with them. They can move their rib cage separate from their pelvis, and then their pelvis separate from their rib cage. They've got fantastic mobility and control. Do you know not one of them could do a sit-up? They were that weak. So my point being, if you have...
Did they have pain?
No, none of them had pain. No.
Okay, that's interesting.
No, but it's just, if you train a lot of mobility, you've got to be real careful with how much strength training you're going to do. If you're going to do strength training, you might be wise to stiffen your back and control the bending. Here's something that this is going to, if you want something controversial for your podcast, here's one. There's a new Nike commercial out showing Rory McIlroy training.
Yes.
Yeah, he's mixing up supreme mobility training with supreme loading. Here's my prediction. That type of training, just like Tiger, will increase the short-term ability to play golf, but he will not last and be a legacy like Nicholas Palmer, Gary Player, those people who didn't train that way. They recognized the mobility needed for golf and the neurology and all the rest of it, but they lasted because they didn't heavily strength train. So my prediction is I think McIlroy's going to be following Tiger on this one, unfortunately. So there's maybe a way to finish that whole idea off.
Yeah, that was a interesting point for sure. And if actually a lot of people ask me about that, like patients asking me about that commercial in terms of that's what should I be doing that? Should I be doing that? Answer is no.
Yeah. You got to be purposeful with your exercise and know what your goals are.
Yeah,
and you can't have it all.
You don't fit the exercise to the patient. You fit the patient to the exercise. So It has to be patient specific.
You're a wise dude.
That's what I like to say. So another question, I didn't practice this before, but a lot of people in the therapy world, in my world, I guess, are following the regional interdependence model of care. And a lot of times I think this is getting blown out of proportion in terms of all the different mechanisms we are seeing for the cause of back pain, from a thoracic ring shift problem, pelvis rotations, visceral issues which can create or manifest as back pain, pelvic floor muscle dysfunction. There's becoming such a big gamut of explanations depending on who you go see for back pain. And I'm wondering what your take is on the expanding role of regional interdependence, both using mobility, stability, and the straight anatomy as to the cause of back pain.
Well, here's my initial thought on that whole thing. The great clinicians. I'm going to tell a story first to give some perspective on this. Newsweek magazine, which is a big magazine in the U.S., they have an issue every now and then on who are the best docs in the U.S. So they called me up and said, "Who's the best spine doc in the U.S.?" And I told them my opinion, and I happened to say, "Well, I would choose Clayton Skaggs, who's the director of the Central Institute for Human Performance in St. Louis." And I said, "Now, do you mean by your question, if I had 20 different types of back pain patients, who would get the most of them together better?" And they said, yeah, that's the question. So I chose him. Now, the reason is because he has a lot of tools in his clinical toolbox. The great clinicians are not married to McKenzie approaches or the pelvic floor or spine stability or thoracic mobility. They do a thorough assessment of the patient. They figure out what the pain triggers are. They stop the pain triggers and coach the patient appropriately, and then they select a therapeutic exercise program to build an appropriate pain-free foundation to move or do whatever the goal is, whether it's just to simply play pickup basketball with their kids in the driveway or it's to win an Olympic gold medal. So that's how I'd answer that. The great clinicians have a lot of tools and skills in their toolbox and apply them appropriately.
So I guess a fair statement with that in mind is that clinicians should not go into a room with a patient with a mindset of what they're going to do. And I don't mean intervention, I mean even assessment, because if you're an FMS guy or SFMA guy and you know that's what you're going to do and you're going to treat based off those results, you might be missing a critical piece to the patient puzzle if that's all your gestalt allows you to see.
Well, I think you've just described what I call a junior clinician.
Okay. Fair enough.
I mean, I don't fill out typical forms when I do an assessment. It's very much a living assessment. So recall I mentioned in describing my assessment, I just have a little bit of small talk with them. And then I have them describe their pain triggers. Is it worse in the morning? Do you get sharp pains when you roll over in bed? I mean, that's a sign of instability, for example.
Yeah.
Tell me about the pain. Is it associated with a particular activity that you do? All of these things. And it's at that time, I then decide what my assessment is going to be. I have no idea what I'm going to assess until they calibrate me and lock me onto an assessment. So even the
absolutely
is a living process.
And a little side.
Oh, sorry. I was just going to say it's a branching tree as well. Like I'll give you an example. Let's do say someone and you're suspecting that they have a dynamic disc, a bulge that grows when they sit in flexion at the computer for an hour and one that shrinks when they go for a walk. Okay. What I would then do is I'll assess them. I will lay them prone on a table and I'll say, put your fist under your forehead. Oh, no, that's too much. Okay. Take your fist away and turn your head to one side. Oh, that's much better. Okay, good. Now, as you exhale, imagine your low back just falling to the table. Just gently breathe some neutrality into your back and try and relax some of the muscles. Then I might go around behind them and apply a little traction load to their legs. And they'll say, I'll say, do you like that? And they say, yeah, I love it. Or the next person might say, oh, actually, that hurts me. So then I'll say, good. Why don't you push your eyebrow down into the table? And they'll say, oh, you just took my pain away. And I thought, well, what I did was I pulled on your legs. I destabilized your back. It caused your pain, but I restabilized it by activating your anterior chain with the eyebrow push. So do you see how that's a living assessment? You're probing and provoking and just playing as you go through this living assessment, learning as much as you possibly can.
Right.
And then just keep following up with more follow-up. So you're chasing with an algorithm. You're not filling out assessment forms.
Mm-hmm. I think what you're saying is 100% bang on in terms of not going into something with a preconceived notion of what you're going to do and assessing based on the patient in front of you. But I think a lot of clinicians, maybe more novice ones, are fearful of that when they have textbook knowledge of why someone has this, what someone looks like with disc pain versus facet issues versus an end plate issue, or a muscular strain, so on and so forth. So when they do the tests based on those preconceived notions of what they should see, and they get a mixed bag result, they can't fit it. That creates confusion, and it creates kind of anxiety in the clinician who doesn't know how then to proceed, because they're like, okay, I thought everyone with a back issue who has a disc problem should have pain with flexion. This person has pain down the back of their leg, but it hurts more with bending backwards.
I can think of two interesting stories there. But one is, about 1 out of 20 disc bulges that I see is an underhooking nerve root. And what that means is when they do a flexion slump, that may increase their reported back pain and perhaps a radiating symptom. And then the slump test says if you then flex the neck, that should increase the radiating symptoms down their leg because of the neural tension. But the problem is if they have an underhook, that takes their pain away. Or if they go into cervical extension, it allows the spinal cord to drift caudally down into the underhooked bulge. So that would really throw a junior clinician. An experienced one would recognize that that's a very particular anatomical type of disc bulge. But having said that, 2 years ago, I think it was 2014, the Archives of Physical Medicine asked me would I write an editorial for the journal. And it was on the reliability of assessment tests. And I said, I could not care less about the reliability of an assessment test, but I know universities and different physio programs and chiro program, manual medicine programs want to have reliable tests. And I said, that only serves the junior clinician. You have to teach them something. So teach them a reliable test. But if it's reliable, in other words, if you get the same score, an experienced clinician, as a newbie out of university, that means it was a very simple test. Everyone gets the same score. But it's not an insightful test. I want a test where you have to probe it, tweak it, push an eyebrow, turn the neck one way, keep playing with neural tensions, capsule tensions, radiating nerve plexus tensions. Really figure it out. And that's a highly unreliable test, but it's the one that reveals with much more precision what that person is suffering from. So
that sounds like it definitely takes practice and being kind of an advocate for your own, as a clinician, as your own career success by taking the time to learn what different test outcomes mean, which I think is so vital that we take the time to go beyond what we were taught in school.
That was the point of the article, but you're right on. Yeah. Mm-hmm. By the way, I hope you're enjoying this. I'm enjoying my conversation with you immensely. You're very insightful.
Thank you very much. I'm enjoying this a lot too. This is so far so good. A few more questions. I'm going to dive a little more into more of a science mode for a second, as opposed to just saying what I think.
Fantastic.
Yeah. So there have been some studies, like Varies in 2010, as an example, that have shown that a neutral spine is not wholly protective against disc damage, and that injuries such as an end plate fracture have been shown to be comparable between both neutral and flex spines when the same loads are applied. With this in mind, how as we as clinicians can be confident that ruling out spinal flexion exercises is safer for patients with discogenic back pain?
Okay, well, discogenic, but we're now actually talking about end plates.
End plates or back pain. Yeah.
Yeah. So the major issue with flexion versus neutral, that's really with the disc annulus. And really that is flexion with cumulative load. That's really, I think every scientist and medic who's investigated that agrees on that one. But end plates, they're a different issue. End plate damage comes from overload and compression. And that is a little bit less dependent upon whether the spine is neutral or flexed. So to protect an end plate, or say you've now documented end plate damage, that was due to an overload of compression, either cumulative or acute, and you can keep adding load, and you'll pass the biological limit and damage the end plate. But again, there's more to the story there. You're based in London, aren't you?
No, I'm in Toronto.
Oh, are you? Forgive me, but you went to Western, I think.
I went to Queens.
Oh, geez. Okay, I'm way off. I'm sorry. We did a study last year. It was just published, actually, where we collaborated with the micro CT imaging group at Western. And we did simulated deadlifts on fresh cadaveric spines. And when you analyze the damage, the first damage that occurs is in the microstructure of the trabecular bone just underneath the end plate. Now that allows a weakness for the cartilaginous end plate to stress wherever that fracture was, and then it will crack and fall into a Schmorl's node or whatever. If it happens to be under the area where the Sharpie's fibers connect from the collagen fibers of the annulus, that's also a precursor to delamination and a cascade that can greatly enhance the risk of subsequent frank herniation. So anyway, getting back, if you want to mention Sam Viries' work, he belongs to a really fantastic research group. It's Robertson's group down in New Zealand. And the particular study that you're talking about, I know it very well. I know all of these people. We did exactly the same work back in 2007. But Viries, I don't know if you really know that paper. They combined torsion with both flexion and neutral in that particular study, and they documented more radial delaminations in the annulus along with the end plate fractures, which is exactly what we reported in the Tempier studies of 2007. So this is now a whole different type of damage linked to twisting plus load. The concentric rings of collagen start to delaminate with the twisting. So this is an important distinction. But you asked about clinicians as well in this. How can clinicians use all of this? And I'm repeating myself now, but it's the same answer. You assess and obtain very precisely the pain triggers of the specific patient. Then you decide on what your particular spine hygiene approach is, which is avoiding or controlling the specific pain trigger. And then you choose what exercises you need to reach your clinical goals with no pain. And I think it's the same general algorithm every time.
Repetition is the mother of all learning. So I think by people hearing this time, gonna ring true. Yeah. So another question I have regarding your work. So many have commented in vitro studies on pig spine models, which have demonstrated disc herniations with repeated flexion cycles, do not actually replicate real world adaptations that both our muscles and bones go through with applied loads. I'm wondering if you can comment on the applicability of those earlier studies you did with what we have physiologically in our bodies that helps us adapt to repeated stress.
Okay, I'm hearing sort of two parts to that. What about pigs, and are they relevant to humans? And what about cadavers, and are they relevant to real life? Are those the two
Yes,
parts that I'm
correct.
hearing? Okay. Well, again, I think it's been a bit unfortunate that there's a couple of people who've made this comment on social media that McGill's pig work is irrelevant. So let me answer that maybe at two levels. Again, let's start with an individual patient who's in front of the clinician, and then let's go to more of a public policy level on this whole thing. So. First, we have to have animal models. I cannot take 50 identical humans and assume that they're all going to behave the same. One's going to be a 90-year-old spine that if you just touch it, it crumbles. And when you work with these things, you realize that. Versus, say, an 18-year-old adolescent killed in a car accident whose spine might have been traumatized. So if you want to control and isolate variables as a scientist, you need a homogeneous study population. So our work on pigs, I can raise 50 pigs, or at least where we buy the spines from can, and there are 50 identical spines. So obviously we'll converge on an answer, but then we have to calibrate that to humans. Well, we've done human studies as well. We mentioned Sam Verries a couple of moments ago. Their group mostly does these controlled studies on ovine or sheep spines. Our controlled studies are on pig cervical spines, which are very close to a human lumbar. If I gave you a pig cervical spine and cut off the anterior processes, I've shown these to surgeons, and they didn't realize that was actually a pig neck, because a pig is a rooting animal. They have a great big lumbar spine with very little mobility in their necks. But then we collaborate with different groups. For example, Mike Adams, a fantastic disc biomechanist in the UK. You must be familiar with Adams and Dolan's work, and they use humans. And by the way, we just found this out yesterday. A paper, Balkovic, Adams, Dolan, and McGill. So again, a collaborative effort on human spines just won the best paper award of the whole of 2015. And we were just notified of that yesterday. So again, people may need to realize that we're calibrating all of these animal studies that give us the advantage of control to humans. So we get that. But now this whole idea of just basing it on cadaver work. When I started out 30 years ago, I hadn't even started the cadaver lab. We didn't start that till about the year 2000. So going back 30 years, we created what we call the virtual spine, which is where computers were really starting to getting going in those days. We would create in great detail the anatomy of the spine. Muscles, ligaments. There was 100 and some odd, 20, I think, muscles crossing the lumbar joints. We had ligaments, dynamic discs of different stiffnesses, etc. And then we would measure the biological signals from the person whose anatomy we represented. As they moved in 3D, we would drive their virtual spine in 3D. And that allowed us to measure their disc deformation, the ligamentous loads, etc., which were all calibrated to their end range of motion. Then we would measure their muscle activity from EMG electrodes and drive the virtual muscles with the signals we collected directly from their motor control strategy. And so we were able to measure the stress distributions, what tissues were being loaded. We were able to measure for the first time and quantify things like spine stability. So people don't realize the extent of all of what we investigated long before we got to cadaveric work. But it really gave us a perspective to understand when we loaded a cadaver spine and controlled the loading, we would apply the loads that we measured in real people. It was a synergy back and forth. So we were able to again quite precisely link different types of loads with end plate fractures that we've talked about, and all the different types of end plate fractures, all the different types of annulus herniations and tears, avulsed ligaments, etc. But the third part of the study, the whole scientific enterprise, we would then go to the clinic and we'd test some of the ideas that we discovered in the basic science end of it and apply them to testing established assessments, coming up with some of our own, testing some of the treatment approaches. And then we did population trials. We just did a study, and I'm going to England next week, actually, to collect the award for this one. It was the top paper in ergonomics last year. We studied the Toronto Police Force, the Emergency Task Force, which are the special very physical police officers. We studied them for 5 years, trying to link different variables to who got back pain and who didn't. So with that whole breadth of the enterprise, we're able to much better interpret what we learn from cadaveric spines, and we test them in humans, etc. So I guess I can conclude this by saying, if your colleagues are discussing what's the role of McGill's pig study, I wish they'd read our low back disorders textbook, which really documents the history and breadth of this science and how we converged on the best positions and ways for people to move and maintain their back health, and how to rehabilitate their backs when they have failed in that.
All right. So my next question is one that I think a lot of people, especially now with the current pain science boom kind of happening, it's been around for a while, but people are kind of gravitating towards it these days more than others, I would say. So there is evidence to show that simply having, for example, poor job satisfaction or feeling an external locus of control at your work or at the home, so you feel like you can't control the things that happen to you in life or how you react to them. Those things increase the perception and intensity of back pain, which have been documented on outcome measure surveys. How then does biomechanics reconcile those psychosocial components that have been shown to alter the duration and chronicity of back pain?
Okay, what a fantastic question. You put a lot of thought into that. So this is going to be fun. I know a lot of those studies because, again, I've had to write policy guidelines addressing these various issues. When you look at the science that support poor job satisfaction or an external locus of control, yes, they have the findings that they report. However, it really isn't complete. So let's look at the studies that support poor job satisfaction. Well, the classic one was done at the Boeing Air Force Company. And they showed that if you had poor job satisfaction, you were more likely to report back pain that disabled you and took time away from your job. But when you really look at the study, they never measured biomechanics. The guys were all doing the same job. And then when you look at the statistics, only 3% of the variance of whether or not they had back troubles was explained by the job satisfaction element. The same thing with the external locus of control. Yes, it's true, but if you measure the biomechanics at the same time, which those studies didn't, you'll find that those people who have jobs with less control, they're in the physical jobs. It's not the manager or the CEO of the corporation who has low external locus of control, but they don't have very many job demands either. It's the guys who are down on the line slaving to a machine where the cumulative load on their back is much higher. So that goes with having a low external locus of control. So you see, it's kind of difficult. So what we need is a study that really measures the psychosocial elements with the biomechanical. And there's only 4 reasonable studies that I know of that have done this. There's Bill Maris's work. And he looked at 130 different manufacturing jobs and really measured psychosocial variables, biomechanical loading. Bob Norman did the same thing at General Motors, looking at different jobs throughout the plant and having matched controls, et cetera, et cetera. Of those 4 studies that made reasonable measures of both biomechanics and psychosocial variables, every one of them agreed that in order to create first-time back pain, you have to have a biomechanical overload. Now, once that has occurred, the psychosocial variables become important. So if you pick a load up from the floor and you're getting older in your working career, you have a much higher risk of getting back pain than picking a load up from waist height. Why? Your hips are a little bit stiffer. It requires more spine flexion. There's more load on the discs. It just makes sense. Then those studies converged on limits. For example, NIOSH, the National Institute of Occupational Safety and Health, they found that around 3,300 newtons of compression is a little bit of a tipping point. And it's true. When you measure all of these jobs, people who repeatedly expose their spine to compression more than that load will have a higher incidence of subsequent back pain. For those building cars, if they have shear load on their back above 500 newtons over and over again, they will get back pain sooner. And that's independent of their psychosocial aspects. But if they have a job that they don't like, they know it hurts them, they're not really keen to get back to that job. I get that. I wouldn't want to go back either. But I'll just take another little clinical perspective. But isn't it so nice to have a scientific perspective together with your clinical perspective? We have different groups at the university that come in for exercise therapy. And if you take a group of, say, breast cancer survivors, it's uncanny when you go in that class and you prescribe an exercise regimen for them and you'll say, do 10 repetitions of that, whatever that is. They'll do 20 because they're type A people. And you have to discourage them. They're overdoing their exercise. Then you get a group of diabetics, which are they tend to be more of the movement adverse people. You have to encourage them to do 10 reps because they'll bargain with you why they only have to do 3. So these are all psychosocial influences. So there's psychosocial forces that influence how a person behaves and magnifies their pain or avoids it. But there are also biomechanical as well. So I hope that answer gives a bit more of a thoughtful and perhaps a more in-depth perspective on this whole, how we consume all of these studies. It's all important. It's all important. And as a clinician, being aware of pay attention to these things, listen to the person, try and understand their psychosocial impediments, or, they might just live in a really crappy part of town. And if they go out and exercise in the park at night, they are risking their lives. That's why they don't do it. That is a psychosocial issue. It's an impediment to them getting better. Mm-hmm. So these are everything is important. I know you know this, Jesse, but for the readers who want to take a side on this, it's a junior thought, folks.
Mm-hmm. I think that's fantastic in that even simply, like you said earlier many times, talking to the patient in front of you, getting to know their hopes, their dreams, what their goals are, how they feel about their life as a whole, really, even if it doesn't do anything in terms of their actual back pain, what it does do is it gives the patient the sense that the therapist in front of them cares and wants to see them get better. That's half the battle right there, I think.
Jesse, I had a patient here 2 weeks ago, and they were getting dressed as they were just about to leave, and I sat them down on the table, and I bent down and picked up their shoes, and I put their shoes on their feet, helped them, and I tied their shoes up for them, and they just burst out in tears. And this was a very tough person, I should tell you. And I said, "Are you okay?" And they said, "Doc, you're the first guy, and I've seen dozens of them. You're the first guy that ever has recognized that I have real pain, and tying my shoes sets me off for days." And he was just bawling his eyes out. And all I did was do what I would do for my mother, my child, or any patient.
Yeah.
Recognize that they have pain and they have troubles, and your job is to help. But they
And
said,
letting them know that you care is so important to them
exactly.
having that team. We're a team in this, as opposed to just being very mechanical and checking boxes and do this, do that, and we'll see you twice a week for the next number of weeks. I think doing those small things, like doing up a patient's shoes, and just that without saying anything, you're telling that patient, I understand that you hurt, and I understand that this hurts you, and so let me help you with this.
Yeah.
So
I
just
remember Brett Contreras. He came. Do you know who he is?
I do.
Yeah, he came up.
The glute guy.
Yeah, he came up to the clinic,
Hmm.
and we spent a day together, and my whole team was there trying to investigate some of his thoughts. And you know what he said to me at the end of the day? He said, Stu, he said, you're amazing. He says, you were out there loading up the bar and putting the 45-pound plates on. He says, I thought you'd be sitting back commanding all the lab. You wouldn't be pitching in there doing all the stuff. And it's the same thing. You show people through action. So is there really this separation between pain science and biomechanics? If there is, I don't know it. All I know is great clinicians are very competent with mechanical, they're very competent with pain science, they're very competent with psychosocial, and they just are good people, and they treat people just as you would treat your mother who has pain. That's what it's all about.
Fair enough. Well said. All right, last question. Okay.
I still have
So,
some resilience left after you
okay,
beat me up so badly here.
last one. You're doing great. Marathon. So your latest book, entitled Back Mechanic, has gotten some pretty great reviews. I purchased it right away, read it cover to cover in about 2 days. I think I've already read it twice, because some of the tips on there take a little while to sink in. Um, you said in the preface of the book that it was made for those who suffer from back pain, looking for ways to help themselves so they can be their own back detective. How do you feel that many clinicians have bought it for their own reading, citing it as an easier read? It's an easier read than your other two textbooks, which were more heavily researched focused.
Yeah. Well, look, I get it, and I know this, and all I can answer to that question is say, look, whatever helps, and whatever I can contribute to clinical expertise and outcome and efficacy. That's all I can really say. But another thought just came to mind. Do you want to hear this?
Sure.
Yeah, your clinicians will get this, and it's kind of an essential part as well to the whole story. I mean, as you know, I've been teaching at the university for about over 30 years, 32 years now, I guess it is, and I've been teaching clinicians probably for about 25 years. And whenever they're in my courses, they'll ask questions, and I'll have to say once in a while, I don't know the answer to that question. But that question is such a gift. That issue or topic, whatever it was that I had to answer, I don't know to, that became our next research project. So it was the clinical questioning that's driven our research for 30 years. So, we've assessed mechanisms of injury and pain, things like, does chiropractic manipulation work? And if so, how? What exercises are effective? Our recent work on sex, for example. Every primary care clinician, I hope you can vouch for this, has been asked by patients, after a bit of bedroom gymnastics, we knackered our backs for 3 months and we're celibate now. How can we enjoy that? And there was no clinical guidelines at all for clinicians on that. So we were the first to measure people engaging in coitus and measuring their back loads. And from that, we created an atlas based on the tissue load. So if you have extension intolerance or movement intolerance or compression intolerance, choose this particular style and you'll avoid the trigger. So anyway, it's the questions from people like yourself that really have guided our research. So I guess what I'm trying to say is I need you as much as you folks need me. So if people want to read the real evidence and the scientific process with references and that kind of thing, they'll have to read my heavy clinical textbooks. But it's not fun reading. I know that. But my new book, Biomechanics, that was the hardest one to write, that took me 5 years. It was easy to write the content, but then I had to keep whittling it down and honing it. What is the most consumable way and the most efficient way that I can get these ideas across? And that's not my style. It's not. My style is to get to the complexity of it all, not to the simplicity. But anyway, I'm glad some clinicians are enjoying it as much as the patients.
So we were just talking about Dr. Stu McGill's latest book, Biomechanics, and it has gotten some pretty great reviews. Many have said that the book, Dr. McGill said the book was made for those with back pain looking for ways to help themselves. My question was, how do you feel that many clinicians have bought it for their own reading, citing it has an easier read feel to your other two textbooks, which are more research focused?
Well, I get where they're coming from on that, but all I can say there is whatever I can contribute to assist clinical expertise and outcome and efficacy, I'm happy with. But maybe I'll just finish off with this last bit, and it's a bit of a story. I've been teaching clinicians for just about 30 years, my own students a bit longer, but anyway, and clinicians will ask me questions, and my answer is, I don't know. But that question that I don't know the answer to is such a gift, because that question forms the issue or topic that becomes our next research project. So that's driven a lot of what we've done over the years. And as I said, I have to thank clinicians for that. Our latest sets of studies that have gotten a lot of press are the sex or coitus studies. And that came from clinicians saying, we get, are you there, Jesse?
I am.
Oh, you're there. Sorry. Clinicians would say, we have patients asking us, how can we have sex? Because 3 months ago we did it, and we've been our backs are just knackered, and we've been celibate because of it. And there's been no guidelines at all for clinicians. So it took us 2 years to get ethical approval, very difficult process to go through. And the lead on that was my student, Natalie Sidorkowitz, a very brave lady to tackle such a thing. But we measured.
I met her, yeah.
We measured couples engaging. We measured spine load, hip loads, motion, spine motion, etc., with a whole variety of different techniques. And from that, we were able to create an atlas and now match specific pain triggers with specific styles. And those are available for clinicians. So my point was, it's people like yourself asking tough questions that have really guided our research. And it's been a wonderful 32 years. I need people like yourself, hopefully as much as you need me. So all of that interaction back and forth over the years was, the real science of it is in my clinical textbooks. But those are heavy reads. I admit that. They're supposed to be. It's not easy. But Biomechanics, that was the most difficult book I've ever written. In fact, it took me 5 years. The content for the first draft was easy, but it took me 5 years to keep honing it and keep rewriting it to get the points down to the essential elements in a very consumable way, even consumable by patients, and from the reviews, it looks as though we're hitting the mark. But anyway, I hope you appreciate that answer, and how much I appreciate.
I definitely do. And like I said, Thank you very much. And like I said, I've read the book and I've taken a lot from it. I've read all three of your books actually. But I've actually used some of the pictures in that book and copied them, photocopied them, given them to patients. Because a section with about the different sex positions and their lows on the back in that book. So if anyone's interested, you can go to backfitpro.com to get the book, Back Mechanic, or any of his other works. Also, sign up for his courses, which he goes all over the world to teach. And Amazon.com also sells his books. I also post links to click on to find exactly where to purchase these products. I want to thank Dr. Stuart McGill for his time today. It was very insightful, and I hope my readers and listeners got some good information from this podcast. Thank you very much for your time, Dr. McGill.
Yeah, Jesse, again, thanks so much. And I hope you've enjoyed this. I certainly have. I'm going to tell you, you were very, very collegial, but you really asked good, insightful questions, and probably some of the most difficult to answer that I've ever had. So I thank you very much for that, and I look forward to the next meeting that we're at, and we can have a beer and a laugh together.
And there will be more to come. That's definitely sure. Thank you very much. Have a great day.
You too.